let me start by saying today, we cannot treat ALL without measuring minimal disease or measurable residual disease or MRD. In fact, when you give any treatment, patient can respond, but yet they relapse. They relapse because there's something we don't see which is present, and that is what we call measurable residual disease. In fact, if you look at the response, when we look at the blast or gone, this is morphological assessment, but that's not good enough. We have to go really deep into the clone, assess this clone, if it's present or not, and tailor therapy accordingly. So in Philadelphia negative ALL, how we measure MRD in the USA and worldwide, there's different assays and tools. Flow cytometry can measure aberrant phenotype present. PCR for immunotherapies receptor, that is done more so in Europe than in USA. It requires, it's more time consuming. It's more sensitive than the flow cytometry. So flow cytometry 10 to minus 4, this was called 10 to minus 5, but yet not ideal. And now we have another test called testing by next generation sequencing or NGS that can allow us to go to 10 to minus 6, 10 to minus 7, really deep to assess the response, because we know if we can get the disease to the maximum depth possible, we minimize the chances of relapse. And that is speaking of MRD. Now, at what time we measure MRD in Philadelphia negative ALL? We know from our data and from elsewhere data from Europe that early eradication of the disease is associated with a better outcome. I can tell you, for example, when we give steroid and Burkitt disease or others, and we measure the response at day 7, that correlates with a great outcome, reflect chemosensitivity and a good outcome. We've shown that if you have an MRD negativity by flow cytometry on day 21, you have better outcome than if your MRD is obtained, negativity obtained at 3 months into treatment. So therefore, my recommendation is to assess MRD from the beginning and look at the assessment in a kinetic way. Look at the kinetic of response, means the level of this at day 21 compared to later on, and see how things are dropping, because if there is dropping, that is a good sign. Now, we've shown that when you compare flow cytometry to MRD by NGS, we have 40% concordance because patients are negative by flow, but positive by NGS. And we've shown as well, if you're negative by NGS on day 28, no patient relapse. Now, of course, the numbers are still small, but early MRD eradication is critical for the outcome. Therefore, in my practice today, I measure MRD at end of induction, which is day 21, 28. And if it's by NGS and by flow, it's positive by NGS, I will keep doing it every month till it clears. Once it becomes MRD negative, I'll do it every 3 months thereafter during the maintenance phase of my treatment, then every 6 months thereafter. That's what I would do for assessment of MRD. And of course, I'll act on it. Early responders may need de-escalation of therapy. Late responders, I may add a blinatumomab or other agents, or even CAR T cells or allotransplantation.